So, those of you who are with us, we are going back to the topic of communications. We had a session on communications yesterday that we saw a lot of you logged in for, but we're slightly changing things up this time. We're going to talk about communications in the context of healthcare, an uptake in AI for diagnostic experiments, personalized treatment plans, as well as in drug discovery and development. In this next session, we're going to learn about how doctor-patient communications can be improved with AI. We have one of my partners in crime, Suzanne Kirkendall, who is joining us from New York this morning. Suzanne is the CEO of BVA Nudge Consulting for North America, and she helped develop an industry-leading social science offering at McCann Health before joining us here at BVA. Much of Suzanne's work is about psychology, public health, and behavioral economics. She did her master's in public health at Columbia and now lectures there. And joining her is Mitesh Patel. Some of you would have met Mitesh at a previous version of The Human Advantage. Mitesh is a physician executive and behavioral scientist. He's currently the Chief Clinical Transformation Officer and National Vice President at Ascension, one of the largest nonprofit healthcare systems in the US. Dr. Patel is also currently an adjunct professor at the Wharton School at the University of Pennsylvania, where he teaches an MBA course on digital transformation of healthcare. He was the founding director of Penn Medicine's Nudge Unit, the world's first behavioral design team embedded within a healthcare system. In this role, he's a world-leading expert in the use of nudges and nudge units in health systems globally. His research is focused on combining insights from behavioral economics with scalable technology to improve health and healthcare. Very happy to have Mitesh back. Very happy to have Suzanne back. Welcome, guys, from the East Coast. Suzanne and Mitesh on the line. Hey, Suzanne. Good morning.
Yeah, welcome.
Hiya.
Good.
It's early, I know. Thanks for joining us.
Yeah, we're happy to be here. And Mitesh, welcome back. As Ted said, I know you were one of our great guest speakers from our very first Human Advantage, so it's exciting to have you back for this third double the size edition. Welcome.
Glad to be back. Thank you for having me here.
Okay.
So first of all, just for those who might not be familiar with all your amazing nudge work and behavioral science work, could you give us just a couple quick examples about your work using behavioral science in healthcare before we turn to the AI part?
Sure. So we started the Penn Medicine Nudge Unit back in 2016, but we had done a couple of experiments before that. A lot of the work during that time, and I ran that for 5 years, we implemented over 100 different interventions trying to change clinician and patient behavior. One of the experiments that really stands out is the one that kind of sparked the light bulb to start the Nudge Unit. That one was around nudging clinicians to prescribe more generic prescriptions. Generic medications are exactly the same formulation as brand name medications, but oftentimes brand name medications are much more expensive. And when we talked to clinicians, they said, hey, we want to try to prescribe the generic as much as possible, but oftentimes we have only a couple minutes in the visit with the patient and we're moving quickly and we just forget to do it. And when we looked at the electronic health record, that's essentially the portal that they use to absorb information and make decisions and then enter orders that the patient gets, we found something interesting, which was that generic prescribing was an opt-in process. That meant that clinicians had to actively take extra steps to make sure it was the generic prescription that the patient got. And if they were moving very quickly, it was easy to miss that. So we did a couple of experiments and found that changing that to an opt-out process, essentially changing the default to the pathway that we think patients and clinicians were most aligned with, had some promise. And we worked with the health system who eventually implemented that for all medications across every specialty in the health system on one day. And what we found was really incredible, which is the generic prescribing rate shot up from 75%, where it had been for several years, to essentially 99.2%. And stayed there for 2.5 years. When we watched it, when we spoke to clinicians, they said they hadn't even noticed the change, but that they were very supportive of it. That's what they had been trying to do the entire time, and now we just made it easier for them to do that. And when we evaluated it, we found if you take the top 100 medications over about 2.5 years, this saved $32 million of unnecessary prescribing. And that was kind of the light bulb moment that working with the health system, we thought, hey, here's an opportunity to really do this much faster. That program evolved over a couple of years, and we wanted to start getting things quickly, 3 to 6 month timelines from identifying a problem to implementing that. And that got the ball rolling on the clinician side. I'll give you one example of patient nudging, and then we'll talk about more about this through the session. One area that we really worked a lot in was through remote monitoring. We were one of the first groups to test wearable devices and their accuracy for remote monitoring. And eventually started off doing some work around financial incentives, but then quickly moved to this concept of gamification. How do we make it more fun and enjoyable and rewarding? And how do we embed a social incentive, a family member, a friend, a colleague from work into that intervention? And what we found was that if we change the game to make it more behaviorally informed, so give you points up front every week that you lose if you don't do your behaviors, add a family member or friend who you either competed with, collaborated with, or got support from, that we could start to test different variations and identify what worked. Our first trial was with the Framingham cohort, which has informed a lot of the heart and cardiovascular guidelines in the United States and across the world. And they had never done a clinical trial. And so we work with them around this idea of enrolling entire families into this and comparing them to families that were also enrolled but didn't have the gamification. And everybody got wearables. And what we found was we nearly doubled physical activity, the proportion of time that people met their goals. Not by giving them a wearable device or feedback, but by layering on this level of kind of behaviorally formed gamification that it encouraged the family to work together and support each other.
Amazing examples. Thank you for sharing. So, of course, we definitely want to focus on AI for the rest of our conversation, given today's theme. So let's start talking about information that patients receive in the healthcare system. We all have received information from a doctor, from some kind of healthcare entity that's very hard to understand, or if not impossible. So I'm curious, Mitesh, this is something I know you've worked on a lot. How can AI help to improve the information that we share with patients?
That's a great question. I mean, the healthcare system is very information heavy. You get all kinds of information. It's hard to make sense of it. I think there are maybe three main problems that I'm sure there are many more, but three big ones that AI could help address. One is that the information's overwhelming. There's just too much of it, and it's hard to sort through all the data and all the information. The second is that when you get the information, there's a lot of medical jargon in there. Clinicians who are very busy and are trying their best to respond to patients sometimes, say things in clinical terms that not every patient is going to understand, and it makes it more confusing. And then the third is the timeliness of the information. Patients often have questions at all kinds of times during the day, and clinicians are actively seeing patients in the hospital and clinics. And so sometimes you have to wait a while to get that information. And so I think thinking about the volume, the clarity, and the timeliness, there's where the opportunity is. So let me give you some examples. So let's say you went to see your primary care doctor. You've been having back pain, you need a refill on your medication, you have 2 or 3 other things on your list, and you go to talk to your doctor. The doctor has a couple of things that they want to talk to you about. You might need cancer screening, vaccination, you might need to get your blood work done again. By the end of a very quick 10 or 12-minute discussion, you've talked about 7 or 8 things, and each of them has a different action step. And oftentimes what you walk out with is, if you're lucky, a post-visit summary, which is a printout of all the orders that were placed and maybe a couple of quick notes the doctor put in. Or you don't even get that. You're just told to log into the patient portal and you can see the full clinical note, which is in medical jargon, or you can see that after visit summary there. So imagine if you were able to take all of that information that I just described, the post-visit summary, the clinical note, the orders that were placed, maybe even listening to the conversation, and then spit out some very patient-friendly instructions for the patient that the patient could understand. So taking the work off of the patient's plate to remember what to do and what it meant and why, and really making it something that they can understand and be actionable on. Another example of this is maybe a bigger case is when you're admitted to the hospital. So we just talked about a clinic visit. You're there for 10 or 12 minutes with a doctor. In the hospital, you might be there for days or sometimes weeks if you have and many things are happening. Hundreds of things are happening a day. It's even harder to keep track of that. And the thing that compounds that is sometimes you go to a hospital that's different from where your primary care doctor or your specialist work. So when you leave that hospital, you again might get discharge paperwork or access to discharge paperwork, but then you go to see another doctor who doesn't even have access to that full record. And you as the patient are trying to sort it out and the doctor are trying to sort it out. So here's another example of where that information could be made less overwhelming and we could try to reduce the medical jargon so patients can understand it. And then there's so we talked about after messaging, then there's in-between care. So let's take the example of you saw your doctor, they say come back in 6 or 12 months, and something might happen in between. Your blood work might come back, you might be due for, like it is now, time for to get the flu season, time to get the flu shot. but your appointment's not until 6 months from now. There's ways that we can use AI to look at the medical record, understand what you're due for, and then automatically send you a notification that's personalized to you. It's not a generic one that tens of thousands of people get, but it's personalized to your medical history and what you need that can help then connect you into care, either a person that can talk to you or someone that can schedule your visit or provide you instructions for how you might get your flu vaccine now, even though your appointment is not for another 6 months.
Lots of interesting possibilities there. So, Mitesh, I know a big theme in your work on AI and doctor-patient communication is personalization. So making content more individualized, sometimes faster, as you mentioned, moving away from what you refer to as a generic algorithmic approach. So when you last joined us for the Human Advantage a couple of years ago, you referred to an idea you called behavioral phenotyping, which is about matching the right intervention to the right person. So can you tell our audience a little bit more about this and some examples you've seen of it being done?
Yeah, that's a great question. I think this is one of the most challenging things in healthcare, and is one of the next big opportunities for us to move the needle. We've done a lot of testing on, there have been studies that have tested 20 or 30 different ways to nudge patients to get a vaccine or cancer screening, whatever it might be. But then ultimately we pick the best one and we implement it for many patients. And what that does is it treats every patient similarly, and it takes the average effect that we found from that study. And what we really need to think about is that every patient has different experiences, they have different preferences, and they have different motivations. And so that means that the interventions that we deploy to them, the way that we communicate with them should differ because patients differ. We shouldn't treat every patient the same way. And so a few years ago, when I was at Penn, we were doing some research around how do we create a concept of behavioral phenotypes. You've seen a lot of research look at someone's age or demographics, such as gender or race and ethnicity, and try to target them based on that information. But that doesn't account for a lot of the personality characteristics that a person might have or their preferences or motivations. And so we did a whole kind of robust assessment of patients in a variety of different clinical trials to see if we could develop these phenotypes, and then looked at what would have happened had we known those phenotypes before the trial went on. So let me give you an example. For one of the first studies we did, it was called the Step Up trial. We partnered with Deloitte Consulting. They wanted to test how do we use wearables to improve remote monitoring and increase activity, particularly among employees that could use a boost in activity. And so we enrolled 600 employees from across the United States into 3 gamification arms. We gave them all a wearable device, and they were randomized to one of the 3 arms or control. The gamification had points and levels, like I talked about earlier, that were behaviorally informed, but they differed in the social incentive. Did you find another employee in your organization to compete against, where you got a leaderboard every week and every month? Was it someone that you collaborated with, where we randomly picked one person and you were both trying to work together to reach goals? Or was it just someone that from your family or friends who was there to support you, who would get a weekly update on how you were doing, was meant to give you a high five, when you were doing well, meant to come in and talk to you and support you when you weren't doing as well? What we found after running a 6-month trial and then 3 months follow-up, just by running those 3 interventions, was that competition worked the best. All 3 interventions worked in a 6-month period, but when we turned it off, we found that competition was sustained. And when you take a step back, you might say, oh, no, these are like young consultants who are, a lot traveling, and that for those type of people, that makes sense. Let's just deploy competition for the entire workforce. But before we started the trial, we did a number of different assessments. We did a personality assessment. We asked a lot of questions about their social risk-taking preferences. And then we asked them a variety of other questions beyond just demographics. And what we found was that there were 3 phenotypes that emerged from the data. There was one group that was extroverted and motivated. Those were the things that stood out about their assessment. And those people, competition worked the best. It was the one that was sustained, just like the overall trial. That was about, a third of the population. We found another group that was less active, but more kind of less active and less social was the things that stood out for them. And so they had lower baseline levels of activity. They were less likely to reach out to family members or friends for support. And what we found is actually all 3 interventions worked. And that's not surprising, right? What they lacked was a social incentive and a way to get motivated. And so in that case, what you want to do is you want to let them pick, because we know from other evidence that if someone picks their intervention, they're more likely to stick with it because they feel like it's something that they've chosen, that they've had a hand in saying, this is what I'm going to do. And so we wouldn't want to assign you particularly to competition. We might give you a menu and let you choose. And then there was this third group, which was about 20% of the population. they were found to be much less motivated, but they were also at risk. They had a chronic condition. They were on the road traveling, most of the time. And so they didn't feel like they could make time for this. And in that group, nothing worked. Just giving them a wearable didn't work, giving them support, competition, or collaboration, nothing worked. That group probably needs more than just a digital intervention. They may need, a health coach or a social community health worker. They may need a visit with their doctor to assess some of the chronic conditions. And so when we work with the organization to think about this, it really stood out that, hey, now that we have these profiles, this might be something that we can do upfront, obviously engaging the employees and the patients, to be engaged in this and those who wanted to do it, but would really help us to tailor these interventions at broader scale.
Another big theme in your work is the topic of clinical workflow, so focusing more on healthcare providers here. So can you speak to how AI can be used to improve the work experience of healthcare providers like doctors who are trying to meet patients' needs under very intense time pressure that comes with the nature of the healthcare system?
Yeah, this is a great question and something that's on our minds all the time. I mean, if you look at the rates of burnout amongst doctors and clinicians in the United States, but all over the world, it is at all-time highs. A lot of this was pushed to extreme levels during the COVID pandemic. But what's been surprising to a lot of people, you can understand during the COVID pandemic why clinicians might get really burned out from all the work that they're doing and so on and so forth. But that a lot of that has not abated since the pandemic. We're still seeing really high levels, and that's been surprising to many people. But if you look under the hood, you just shadow a clinician for a day, you'll see why. They do a lot of administrative work. They are writing notes. They are trying to do documentation. They have orders that they know are right for patients that they need to go and get approvals for insurance to cover. And then they go home and they have to deal with all the messages that patients, they may see thousands of patients, those patients messaged in who weren't in the clinic. And this has often been referred to as pajama time, when clinicians are, after bedtime, are in the electronic health record, catching up, either writing their notes or responding. And so the opportunity here is, there's several things, but one is to significantly reduce the administrative burden on clinicians so that they can be spending more time on doctors, so they can spend more time communicating with patients and providing care. And so one example is around when patients and doctors are in a room together. A lot of times, if you've been a patient and you've seen a doctor, you might notice they're glued to their computer. That's how they put in their orders. That's how they write their notes. The more they can get done during the visit, the less they have to do later. There are now technologies that are, ambient AI that will listen to the conversation with the patient's consent and summarize the note. It can get 95% of the way there, and the clinician can spend their time talking to the patient as opposed to typing into a computer. So I think that has a lot of promise, and we're already seeing health systems embrace this and then roll this out throughout their entire organization, and that it's reducing the amount of time that clinicians are spending in the electronic health record, both during the clinic day and at night. Another opportunity is that clinicians are, just like patients, trying to absorb a lot of information. A new patient might come to them and they may be at that health system for 5+ years, and now they're getting referred to cardiology because they're having some chest pain or palpitations or something else. That cardiologist needs to quickly understand who the patient is, what might be driving their risk factors, and so on and so forth. You could think about ways that we could, as opposed to what currently happens, was clinicians just quickly scan through the notes and try to take a summary and maybe jot down some of their own notes and try to figure out what's going on. They might look at the lab section. You might have a minute or two in between patients to do this before you just go into the room and talk to the patient. What if it produced a summary and said, hey, this is a 62-year-old patient who's been very active, but recently has developed shortness of breath and chest pain, coming in for an evaluation of cardiac disease. Something like that could be generated very quickly. Obviously, the clinician would need to check those key points and make sure that the data supported that, but that would just make it easier for them to sort through the mess. So I'll give one more example here and then pause. The other thing I think clinicians do a lot of is they're searching through the electronic health record. You have a patient here who is of the age where they may be needing colon cancer screening, colonoscopy, or a stool test. And the way to look at that is to see if you can find evidence that they've had that. You can ask the patient, hey, have you had a colonoscopy or a stool test? Sometimes patients remember, sometimes patients, just given all this stuff, they're not sure. And even if they say they are, you want to know the results so you can understand, do you need a repeat test in 5 years or 10 years? And they're just searching through that. I mean, what if you could just ask the EHR a question like you asked ChatGPT? Hey, is there any evidence in the medical record of colon cancer screening. And it would do the searching for you and then try to find and say, actually, there's a reference in this note to a colonoscopy that was done in another health system. We don't have the record, but it was done in 2021. And so that may help you have a better conversation with the patient to remind them and also say, okay, it's 2024, 3 years later, you may be due next at this time point.
A lot of really interesting examples, and I know we'll get to more, but something that is really important to talk about when we're talking about AI in health is safety. So what guardrails do you think are important to put in place to protect patients and doctors using AI in this way?
This is really important. I mean, in every field, but particularly in healthcare where patients' lives are at risk. I think this is something that's going to make or break how quickly the adoption of these AI tools happen in healthcare. I think one of the ways to look at this is that the initial use cases around using AI in healthcare are more around augmentation than automation. Now, there are very kind of administrative tasks that you can automate that may be related to scanning documents or just things that AI can do very quickly that don't influence clinical decisions. But when it comes to making clinical decisions in the early stages of this new adoption and change in technology, it's going to be more around how do we augment clinicians and patients in their conversation in a way that induces shared decision making so that they can make decisions. So I'll give you a couple of examples of this. There's been a lot of interest around patient portal messaging. So patients don't have a visit schedule with their doctor, something happened, they reach out to their doctor using the secure patient portal to ask a question. Hey, I've had this thing come up. I'm wondering whether I need to be seen or if I can just go to the pharmacy and get something to help address it. Clinicians struggle to respond to that in a timely way because they're seeing patients throughout the day, and then they have to go and do this oftentimes outside of their clinic or outside of the hospital. And so one way that has been recently tested is, hey, we've got access to the patient's chart. We see their questions, so we know their history, because their history might matter. If someone says, hey, I have a headache, and it's your first headache ever, that's different than if someone reaches out and says, I have a headache, and you see that they have a history of migraines and they have medications that they're taking, which might differ from another patient who just had a fall and has a headache. And so the context kind of matters, and AI can actually use the medical record and generate a draft response for clinicians. So as opposed to clinicians having to do this from scratch, they could generate a draft response, and then they could send a message. They can obviously review it and send a message back to patients. Now, there are a couple of steps in that could be put in to help make that more safe. So one is to make sure that clinicians need to review the message. There's no way for the message to automatically be drafted and go to the patient without a human, a clinician in this case, reviewing and signing off on this information. There's a couple of different ways you could just, make sure that a clinician checks the box. You could have some time limitation, or you could just, in addition to probably training of clinicians around this, and I'll talk about that more in a second. The other way is making it transparent to patients so that they know when AI was used. I think that actually increases trust. Ultimately, what we're trying to do here is improve trust in make sure it's safe, but improve trust in the process. And so we've seen some health systems launch this where at the bottom of any note that was generated by AI, it actually says, hey, this note was, or this message was generated by AI, but reviewed by Dr. Patel at this time before it was sent to you. And so they know, hey, this was queued up for clinicians, but my doctor took a look at it and made sure that the information was right. And then I'll go back to something I mentioned earlier as another point is clinicians are not trained to use this stuff. They're not trained for a lot of things that technology does. They're trained to provide clinical care, but when the pandemic happened, a lot of clinicians changed to virtual care, doing telemedicine. And there wasn't much training, for clinicians that have been working for a while, 10, 15 years ago. That wasn't a modality. And so there's not training on virtual care, but we've now gotten up to speed at that. There have been sessions on, how do you document, how do you order, what's appropriate for a virtual visit versus in-person visit. Those same type of things need to evolve for AI tools, but they need to evolve at much faster pace. And because the technology is evolving at a much faster pace than we've seen before. The pandemic really accelerated virtual care, but virtual care had been around for a decade and really still is on that adoption curve. It's now being used and patients are much more used to it, but clinicians we're never trained in that. And it took a while to get clinicians trained, but AI is going to evolve much quicker than that.
Absolutely. So I'm curious, Mitesh, we've heard some examples already of this happening. This is a space that evolves so quickly, as you said. So where do you see AI taking us in the future in healthcare and doctor-patient communication, both short-term and longer term?
Yeah, that's a great question. And I think, in the short term, there are opportunities. We've talked about some of those today where we can really augment clinician and patient communications, mostly by reducing the overwhelming information, making it more clear, and then helping to, almost act as a co-pilot for clinicians and patients so that they can, understand what they need to do and get access to the information that's really useful, as opposed to having spending their time combing through lots of information to find the right thing. I think those types of use cases we're already seeing being implemented. The MBA and AI voice technology for clinicians and patients during a visit. The patient portal messaging is drafts. There are some electronic health records that have that already available for their clinicians. And those are mostly like a workflow augmentation around information. And I think that's going to require a bit more testing to get scale, but it's going to go through pretty quickly because we're seeing the impact of that already. I think long term, there is opportunity for that other part that I mentioned earlier, which is the automation of some of the lower risk of healthcare around how do we actually move into clinical decision making, helping guide patients and things that are lower risk that don't always require a human, or that can plug in a human when they need to do that. But that's going to require a lot of careful testing and evaluation, putting the right safeguards into place, making sure we know when things work and when they don't. Oftentimes in healthcare, that has taken much longer than in other industries. And this is an area where I think it may move faster just because the technology may race ahead. And so we need to think carefully about how we're going to do that. So to give you a couple of examples, you can imagine that if you look at all the messages that patients send to doctors through the patient portal, you can probably, a bunch of them may be around prescription refills. Others may be, hey, I have a fever, rash, cold, cough, etc. Some of those things you can very quickly tell, hey, this is a cold, you might want to do this and then check back in with us in 2 days. Other things, you might see signs of where, hey, we really need to come in and understand whether or not you have pneumonia or not. So how do we tease that apart? What's a cold and what's pneumonia? We can often ask you a couple of questions to help triage patients. A lot of times patients are told, regardless of either one, come in and see the doctor. But really, the patient who has a fever, who has a history of something that might make them more susceptible to pneumonia should come in right away or go to the emergency room. And the patient who just has a cold should be given some advice around that and what to monitor. And then we should automatically send them a check-in 2 days later. So you can imagine how an AI system could help us do that at large scale. That would reach many more patients and give access to much faster care than we can do today.
Very exciting. So we started with the question about behavioral science. As we get close to the end, we're going to come back and reflect on that again. Last time you joined us at the Human Advantage, you mentioned that you were really excited about a future where behavioral science is embedded in the healthcare system as just how we work, not as something special or exclusive. How do you think that's progressed in the last couple of years?
Yeah, that's a great question. I mean, one of the reasons we started the Nudge Unit was to try to embed behavioral science more into health systems. And one of the things that we did initially, and actually the next one is happening next week, is the Nudge Units and Healthcare Symposium. Penn Medicine Nudge Unit, now led by Kit Delgado and team, is hosting another one of these next week. And I'm excited to go to that. It essentially brings health systems from all over the world to the Penn Medicine campus to talk about and share insights around what they're doing, embedding nudges within their health systems, sharing best practices, helping them then go back to their organizations. That has really grown over the few years, and it's been great now that I've left to kind of see that continue to evolve. I think there's a lot more examples of interventions at broader scale. We particularly saw this during the COVID pandemic, where there were messages to try to get people vaccinated. But we're also seeing in other spaces, how do we improve cancer screening? How do we improve more prescribing of things that are good for you, like statins, less prescribing of things that aren't, like opioids? These things that are really challenges for the broader field that we could implement. And then what's been exciting to me is not just seeing it in health systems, but now seeing it within insurance plans, within governments. Some of this is spilling over into those areas as well. And I think that that's really exciting. I do think that there are opportunities to continue to advance this in those areas. A lot of those programs and things that are there are sometimes kind of like one-offs. So for example, if you're sending a message before a doctor's visit around vaccination, you've got your normal appointment reminder, appointment confirmation, and then you've got a separate text message that tells you, hey, you're due for the flu, talk to your doctor about it, and has some behavioral science message embedded with it. But what if that message was just within your appointment reminder and confirmation as opposed to separate? How do we take these things and really make them embedded within the operations of a health system? I know we're working on a lot of that stuff at Ascension, and I think that there's opportunities for health systems and other organizations more broadly to think a little bit more holistically about patients, and then how do we fit that within the operations. I know you had John List on before, and I think one of the things that really jives here with the voltage effect is that you can test things in clinical trials, but when you put them into the real world, there are drops in this in terms of how the impact is, because you haven't accounted for certain things. And so here's an opportunity where we can test things within the operations of a health system, a health insurance plan, a government agency that's focused on healthcare, and really see what the impact is at scale. And then it's not I have to keep this running through a research grant or something else. It's a part of the core operations. And I think we're moving there, but we still have more work to do.
Very exciting. So unfortunately, we're coming to the end of our time. I know we've just scratched the surface of a really exciting topic. But for those of us who are listening, who are interested in perhaps looking more into this or doing this more in their own work, what would be your final advice for someone who's in a healthcare setting, a pharma company, a health system, or anyone who works with them about how they might start to integrate AI in doctor-patient communications?
Yeah, I think there's a lot of interest in this because people can see how AI is having impact in their own lives, in their daily things. You have a question, you don't know what the answer is, you could just ask, Gemini or ChatGPT or one of these tools, and they're thinking about how would this impact healthcare. But to some sense, some people can look at it as kind of overwhelming, or look at all the challenges around the safety issues and say, I'm going to wait a little bit. I don't know exactly where to get started. It's a bit too complicated in healthcare. I'm worried. And my advice to folks is to, embrace that, use that to think carefully about how you're going to design stuff, but don't shy away from it. Look for opportunities where you can start small. You can partner with other folks in your health system, other academics, other organizations who have experience in behavioral science, AI, and other tools, and think about how can I make an impact on patients. I think that's ultimately what's going to make the difference between how long it's going to take for this to have a huge impact, and whether or not that's done in the right way. If we don't step in and do this carefully, it's going to expand quickly and quickly get out of hand, and without the right safeguards in place. And I think there's an opportunity in the middle here for us to start small, test carefully, run experiments when it makes sense, and learn quickly so that we can start to take the technology and use it to maximize benefit for clinicians and patients over the long term.
Amazing. Thank you.
If we can steal a little bit more of your time, Dr. Patel, we do have some questions coming in from the audience. I realize, Suzanne, you can't see those online, so I'm butting in. Mitesh, given that this comes from the audience, given that misdiagnoses often stem from cognitive biases or gaps in primary care, do you see potential for AI and longitudinal EMR integration to address these issues while also balancing privacy concerns? Not an easy question, but
yeah, a lot to tackle there. So I think privacy is, especially in healthcare, in any sense, is really important. And so making sure that we're transparent, that the patients know how we're using their data, but then also doing it in a secure way. So not taking a patient record and then just putting it into ChatGPT or something else. Thinking about how do we do this in a safe way, in a secure cloud. Those are some things that health systems have to think about. I'll give you an example of where I think this could be useful addressing cognitive biases. And I actually, found this example online when I was writing a blog post, which is a suggestion for the blog post was like, hey, take your blog post, put it in ChatGPT and ask ChatGPT, what are 3 questions that your audience may have after reading your blog post that you didn't address in the question? And then go ahead and answer those questions. And what it really gives you is like 3 things that you didn't think about when, you spent weeks writing this post, you didn't think about it. So think about if there was a secure way within the electronic health record for a clinician to do this with their note. They just spent 10 or 15 minutes with a patient. They listed all the key diagnoses, the EHR has access to everything else, and then they listed the plan. This is a 62-year-old patient coming in with these 3 problems. Here's what we think it is, and here's the test that we're going to do. What if they could just simply do almost like we do a spell check when we're doing documents. It's almost like a diagnosis check. And it would just say, hey, have you considered these things? And so it could give you some suggestions that you might have overlooked. And then it also give you some things like, hey, if you want to consider this, here's the test that you might order. And that might be something that it's just another laboratory test that makes a lot of sense, and you could just do it while you're doing other lab tests. So I think that's a really quick way to help, using something that's already existing within the EHR today to help give clinicians a check. Did I miss anything? Was there something that I wasn't thinking about because of the time pressures or other cognitive biases?
Mm-hmm. If I can, Suzanne, we got another question that's getting some votes here. Are doctors receptive to these nudges and these interventions? You know, how do you make sure they don't feel attacked or challenged when in fact you are challenging their current communications habits or patterns in the doctor-patient communications?
That's a great question. I mean, we're working with clinicians who have spent decades becoming experts in what they do, and coming in and saying, hey, there's something that we can do, help you to do better is really challenging for people to, and oftentimes it requires changing the way they practice. So what we've done in the past that's worked really well is, rather than go to a group and say, hey, we're going to do this for you, is to actually have the questions come from them. We do things like crowdsourcing tournaments where the clinicians can tell us what are the top problems that they're facing, and then they can pitch their ideas to us. A lot of times clinicians have these great ideas and there are things they've been working on for a while that they haven't been able to get progress on. And if you have the opportunities come from within clinicians, and then you work with them to identify something in partnership that could fit within their workflow and solve their problems, they're much more receptive, and the intervention's better because you designed it by listening to a clinician who's actually in the field and is within the workflow, as opposed to taking an outsider perspective. So I would advise anyone that's thinking about this to partner with clinicians and work with them, and any opportunities to have them source the idea is going to make it more likely to succeed.
A bit of IKEA effect in clinic, yeah. Another one that just came in is, how do you guard against the doctors under this time pressure to not then be overly reliant on the AI guidance or suggestions and losing their actual input? Is that a risk that you've seen?
Yep, and there's definitely risk to any of these technologies. I think one thing we have to understand is that clinicians already have time pressures and they're relying on things already. And a lot of these tools don't have the intelligence that AI might have. So they're simple checklists, and things of that might be incomplete with information. So it might say, patients due for colon cancer, but it doesn't tell you if the patient's had a colonoscopy or not, because you have to go do that manually. And so I think there are opportunities to make the existing tools that clinicians rely on day to day better by using AI. But that does have to be done carefully. Again, augmentation, not automation in the beginning stages. And so how do we help that be a tool? One way to think about that is if in that example is if we say, hey, patients due for colon cancer screening, their last colonoscopy was 12 years ago. Maybe that gives you some information to find that colonoscopy report. You can click on that information as opposed to just saying it. And so the corollary of this is ChatGPT, some of these other tools now give you links to where they got their information from, so that you can go back to the source data and actually make sure that what you're relying on is actually true and interpreted in the correct way. Mm-hmm.
Suzanne, jump in anytime. Otherwise, I'm going to just keep going through the audience once.
I do have a question. I think, right now it's an interest, all these kind of considerations or examples are examples of complete paradigm shift in the tools trying to be fit into an existing system and existing roles for doctors. And there's some growing pains with that. What do you see the future role of doctors being? And how does this change medical school? Thinking about what these tools are going to do to the healthcare system.
Yeah, I think, we've always had a shortage of clinicians and nurses and other staff in the hospital. So I think this really gives us an opportunity to provide care to more patients that need it, to provide care in a more timely way, getting the patient to the right place in the right setting. I think that there's going to be new I think right now universities, business schools, and so on are thinking about how do we incorporate the fact that, students have ChatGPT and other AI tools accessible to them when they're writing essays and drafts. So we're going to have to think about the same thing for how do we train medical students when they're going to be practicing with ambient AI that's listening to patient conversations with, these tools in the electronic health record. But I think one other important thing that we learned during the COVID pandemic from virtual care was we also have to think about the same thing for patients. So, how do we get, when it came to virtual care, we had to think about how do we get patients used to logging in to their phone? How do they use Zoom or whatever the capability is? The same thing is going to be true with AI. This is something between clinicians and patients. And so we're going to need to think about how do we guide both of them and educate both of them in the right direction to enable the tool to its fullest use.
Great.
Don't want to monopolize.
Please go for it. Go for it, Suzanne.
No, go ahead. We want to hear from the audience.
This one's a little bit tricky because I think you've talked about some of this, Dr. Patel, but are you leveraging behavioral science in some kind of practical but meaningful ways? HCP segmentation to inform rep targeting, or we've talked a little bit about message delivery, or any kind of omni-channel execution. Any other examples? I think some people from the healthcare sector are looking for some really concrete examples.
Yeah, I mean there are lots of examples here. So there's a whole set of examples on clinicians in the electronic health record, active choice for changing the default to something that we know is evidence based makes a lot of sense. But a lot of times we need patients and clinicians to have discussions. So we might prompt the clinician to make a decision, or we might prompt a caregiver. Peer comparison feedback. We've done some work around how do we give clinicians feedback on their prescribing to influence, and we found it can increase statin prescribing for patients with heart disease and decrease opioid prescribing for patients that may not need an opioid and could use other drugs. So there are opportunities there. On the patient side, there's lots of opportunities in the way we communicate with patients. And so I partner with colleagues on some large studies around vaccination, cancer screening, and how do we message that. And what we're looking at more now is how do we give them a holistic digital care plan and think about a broader set of things. It's not just you're due for a flu shot. You may also be due for cancer screening, and you may need a statin or whatever it might be. And so how do we think about leveraging all of that information and providing you a care plan that can then empower you to act in your health, act in your best interest, and then inform a discussion. So we might deliver that to you right before you see your doctor so that you know, hey, I have these things I need to talk about. Or we might deliver that in between, when you're in between, and then we can use AI to learn. How do you react? Are you someone who will never get a flu shot and we should move on to thinking about other things? Or are you someone that has questions about a certain behavior and we should give you guidance to that, or connect you with someone who can answer your questions? And so I think there's a lot of ways to take these communications, make them more personalized, and then leverage psychological ownership and these other concepts within the messaging that we send to patients.
Great. I think we are bang on time, guys. That was really great. Thank you, Suzanne, for hosting this. Thank you, Dr. Patel.
Thank you for having me.
Good to see you. Hi to the New York-based team, Suzanne. We'll see you soon. Thanks, guys.
Thank you.